To staying healthy. That is integral to nursing. So for all of you who are nurses in the room, I want to give you a special applause because we have a special place in the delivery of healthcare. But we are part of a team, and it's how we communicate with each other, how we help our physicians and our providers set a plan of care. That is our role, to be part of that team and help to deliver that ongoing care so that our patients can live as healthfully as they possibly can. As nurses, we often are viewed by the public as one of the most reputable professions in the world. Frequently, we result very high in polls because of what we do and how we do it. So as I and others on my team, and when I say nurses, I want to include the CNAs, the medical assistants, the LVNs, the RNs, the nurse practitioners. We daily impact our patients. And as part of that interprofessional team, I think we are all very proud that we are part of that and have helped in this fight to care for our patients, to develop new treatment plans, to provide information and participate in research projects. All of this has led us where we are today. So interprofessional teams, to me, is very personal because I learned that entire approach in dealing with patients with HIV and AIDS. So thank you and welcome to each of you this morning.
So it's my pleasure to introduce our first speaker of the day, who I'm really proud to say is a long-term colleague and friend, I hope, of mine. He is a very well-respected and published international physician and infectious disease specialist, a lover of camembert cheese, and heads our injectable treatment division at Eisenhower Health, Dr. Cyril Gaultier.
Good morning. I hope you're more awake than I am. Today, I'm going to try to summarize the real-world experience that was presented in the three big conferences this year at CROI, IS in Germany, and ID Week in Los Angeles. Last year, I gave a presentation about long-term injectables. Let me see if this works. These are my disclosures. I thought instead of going through the data again, I would just give you what has been presented in terms of real-world experience, because we know the data, we know from the data that the injectable therapies work. The question is, how implementable is this? And there will be a talk from David and Kimberly a little later. So let's start with PrEP. The first injectable for PrEP currently available is cabotegravir, Cab-LA. And this is a summary slide from CROI, which early in the year looked at the multiple databases that regroup multiple different cohorts of patients from women, trans, Latinos, African Americans, and each cohort is specific for those particular issues. But I think the salient point I want to make is that the rate of seroconversion in the upper trial with 560 participants is only 1, and on the Howard Brown cohort is also only 1. The rate of discontinuation is between 7 and 16%. The rate of on-time injections is surprisingly not amazingly great, but this is a testament to the value of this compound, that even with poor testing and poor on-time injection records, you still only have 2 seroconversion for this very large body of patients. At ID Week, there was a bit of a rework and retool of the data, but basically this now shows the effectiveness of CAB-LA at around 99.7% and 100% when it was reported. The other cohorts didn't report, this one did. But these were, again, multi-centers, several areas. And here's the breakdown of diversity profile for these patient cohorts, which was Black 30%, 28%, Opera and Trio lead there, but also the San Francisco cohorts and the Howard Brown. So again, very encouraging data that even in suboptimal circumstances, we still achieve very high rates of suppression, of prevention, with CAB-LA. This is a little bit of a further breakdown of the Opera and the Trio cohort, and I'm sorry, the slide is very busy, but I'll just highlight the percentage of women, which was listed here, Blacks and Hispanics, and then also the Trio cohort there. Injection delays. So as you can see here, the injection delays were quite significant, 32%. And I can tell you from real world experience, PrEP patients on injectables is like herding cats. To get them to show up on time for their injection is quite remarkable. And they do show up, and then they like, what do you mean I had to do blood work? Well, that's the whole point of PrEP, is that we want to make sure you don't have HIV going to this, so we're not falsely suppressing you. Anyway, so, but thanks to Kimmy and David and my whole team at Rimrock, we are tackling the problem. All right, what's exciting about CAB-LA? So there is data that was presented at CROI earlier this year that talked about a new formulation of cabotegravir, which will hopefully be able to be given every 4 months, thanks to a retooling of the suspension, which is a nanoformula. And at CROI, they presented very exciting data, both through sub-Q administration versus intramuscular injections. And without trying to explain this very difficult curve here to the right, it shows that basically both achieve very nice therapeutic levels with a very slow curve, and the curve is actually flattened out a little bit, making you understand why this is going to work very well. And then the half-life of the new reformulated cabotegravir, the ultra-long acting, in the sub-Q was 6 times higher than the regular CAB 200, and the IM was twice as long. So we're very hopeful that this is going to be very helpful to give you a new PrEP every 4 months. And a little plug for my colleagues at BIOS Research here in Palm Springs, which will be enrolling this trial in the next month or so. And lots of excitement there. So as I said, very favorable tolerability and safety profile. PK was very exciting. And the doses are 2.7 higher than the current approved dosing, and they're also looking at some subcutaneous administration, which may lead to perhaps patient administration. All right, what is the other injectable PrEP available to us? We have some lenacapavir, a very exciting compound, a capsid inhibitor, which has, unlike many of its other colleagues, mechanisms of action that interfere with the viral life cycles in 3 different points: nuclear transport initially, capsid inhibition of assembly and release, and capsid assembly. So a very exciting compound. This year at ID Week, they presented the very landmark study of Purpose 1 and Purpose 2. Purpose studies was a group of studies looking at very different patient cohorts. The first one, Purpose 1, is mostly in cisgender women in South Africa and Uganda. And then purpose 2 was mostly 5 or 6 countries looking mostly at MSM and transgender and non-binary. And then there was a few cohorts that have not been reported yet, as far as I know. A quick reminder, the purpose 1 is a comparison of lenacapavir, FTAF, and FTDF. And this is again in South Africa mostly, and given for 52 weeks. And purpose 2 was a comparison of lenacapavir versus FTDF. And this was in 7 countries, as I mentioned. There was no FTAF arm in this. This is the regional distribution: South Africa, Uganda. And purpose 2, mostly United States, a little bit of Mexico, Peru, Brazil, Argentina, South Africa, and Thailand. So a pretty nice representation, and a very heavy emphasis on non-whites, Hispanic, Latino, and gender diverse. Very busy slide. Basically, this is to say that they were pretty well matched. But these purpose 1, the age group was young women of reproductive age, with this where this is very important. And the results have basically showed there was no seroconversions in cisgender women receiving lenacapavir. And in purpose 2, there were 2 incident infections patients on lenacapavir, and this is the secondary cohort. The primary analysis shows that basically the lenacapavir has 100% efficacy for PrEP, and then in purpose 2, 96%. So similar results to what we've seen with cabotegravir. But the data from South Africa in women of reproductive age was very important, because, as I'm going to show you in a minute, there's a very big issue with compliance with oral PrEP in Africa. Then they try to look at the superiority versus TDF in both arms, and showed the same thing. So this is a adherence slide, and basically whatever is in red is low adherence, and you can see that by the end of the year, basically 90% of women were not taking their oral PrEP. So very few people were still taking oral PrEP, which explains why this trial showed no protective effect of oral PrEP in this particular cohort, as opposed to the other arm, which showed 100% protection. And this is largely due to the fact that there is a lot of stigma associated with taking PrEP in women in Africa. And basically, there were some very moving slides about violence against women when they were found to be taking PrEP, and how this injectable therapy allows them to receive protection without having to disclose and not suffer the violence. So that, again, 0 infection in cisgender women, and again, the oral PrEP did not help very much, because adherence was so terrible. Purpose 2, slightly different population, for the most part, men, and this showed 96% efficacy and superior to 89% with FTAF and FTDF. I apologize. All right. Again, lenacapavir fairly well tolerated, as patients often complain that, I have a nodule, and I try to explain that we've just put 6 months worth of medication in your abdomen, and it's not going to go away overnight. So you are going to have a lump. And sometimes I sell it, we're going to go from a 6-pack to an 8-pack, because we give it right here. That's not selling very well, by the way. Try to keep it light. Anyway, so well tolerated, and very exciting. Now we're looking for pricing, when and if it gets approved by the FDA. All right. Switching gears to injectable treatment. So again, long-term injectables. The first one in the category, I'll reverse the order. We'll start with lenacapavir. This year, they presented 3-year data on the Capella trial. This was a highly experienced group of patients who had very few options, and they were randomized to lenacapavir with optimized background versus lenacapavir PO optimized background, and then sub-Q, and then the final group PO, then sub-Q. And I think the total amount of patients was 70 something, which 77 or something, 72, sorry. So not a very large group, but what was interesting is it continues to perform well. In the first year, there was a few dropouts because some people had very or no active drugs in their optimized backgrounds, but once they suppressed, for the most part, they did well. And then this is the CD4 slide at 104 weeks. So about 122 cells over the course of 2 years. And then virologic outcomes, this is the 156 weeks. I think this was at ID week. And it shows that, once you suppress at week 26, you stay suppressed for the next 2 years, which is really amazing. There was about 23% of patients who didn't have data missing, but only 11 with true virologic failure. So that leaves us with a 61% success rate at 3 years, which is pretty remarkable with a drug where you may or may not have a lot of options. Again, this is sort of a snapshot, a very busy slide. But what's interesting to me is that once you pass the first 26 weeks, there were no new cases of len resistance. In other words, resistance doesn't emerge once you've passed, you're able to suppress the patient and continue. And the virologic success is right here again at the different time points, 52 weeks, 104, and 156. All right, cabotegravir, rilpivirine. Interesting information that I got from one of the conferences was, can we give Cabenuva subcutaneously? And they did this very nice little trial called the FLAIR trial, and they looked at first starting patients on IM and then switching to sub-Q. And looked at the concentrations of cabotegravir and rilpivirine, and as you can see, the numbers look really good. However, patient-reported outcomes were not amazing. The sub-Q injection preference was 34%, but a clear 60% of patients were like, this is not for us. The issue was the site swelling and nodularity, and pain was quite high. Rilpivirine, for some reason, has a little bit, it's a denser suspension, it seems, and it seems to be much more uncomfortable. And we see that with the IM administration. So I don't think we're going to pursue a sub-Q for Cabenuva. An interesting summary slide from, I think, from ID Week, where they looked at all the different trials of FLAIR, ATLAS, and SOLAR, and they showed that despite what you may be seeing in patients on long-acting injectables, is that the incidence of mini blips or virologic flares, so to speak, do not correlate with resistance. And that was very, very helpful. And I'm telling all my patients about this. But these were pooled analyses of four phase 3 studies, and showed that the confirmed virologic failure rate was less than 1%, despite mini blips. And by mini blips, I mean less than 200. So I thought that was good news. And then high efficacy continues to be shown across all the different cohorts that I mentioned here. Biologically suppressed with ATLAS 94, 87%, and 90%. and virologic failure is still less than 2%, 1%, and 1%. And then pleased to report, I haven't personally seen virologic failure, but I was just speaking with a colleague who has had 2 virologic failure, and one of his failure was, not surprisingly, a patient with a genotype A6, which is one of the few failures that were reported in the initial registering trial. The other patient remains a mystery as to what happened. Again, this is looking at the upper trio combined Carlos and Beyond trial, multiple different cohorts, and the virologic failure remains less than 2% on average. So the emphasis also this year was on how is this helpful to have patients on injectable therapy. And as you probably realize, the amount of interaction you have with the patient in the year, because it's every 2 months, is actually very strong. So every 2 months, there's a contact with the patient. And what they've been able to show, so between a Credo, CVS Specialty, and OptumRx calling the patient incessantly to get the right address and where do we deliver and are you still taking your medication and et cetera. So they've noticed it's been a big improvement in adherence, because between my staff and the pharmacy staff trying to rally the patient into the office, we get them to come, and we can also monitor their weight and metabolic syndromes. We can also report on the fact that this combination medication does not affect renal parameters nor bone biomarkers. We keep the patient engaged in care with a high retention rate. I would say the rate of patients who discontinue Cabenuva in the original trial, I think, was less than 1% related to injection site reactions. And I would say that's pretty correct. Most of the patients who have asked to go off to Cabenuva is really either needle phobia, which tells us they probably should have never been on it, or moving out of town, or having some other personal issue and it's just too complicated to come in every 2 months. But I would say maybe 2 patients actually stopped because of the injection site. So we're about 150 patients at Rimrock taking Cabenuva. And the quality of life, I think I reported on this last year. The Solar 3D trial looked at the quality of life that patient reports by taking injectable therapies and taking away the daily reminder of having to take a pill, taking away the stigma of having to disclose the pills, and just coming to the doctor's office and getting an injection is a private transaction that nobody else knows. And so that I think is really very powerful for our patients. And then finally, I think the high retention in care is very helpful. And they did also an analysis of all the different randomized clinical trial, but also the real world experience cohorts, the Carlos, the Beyond, the Alana, and the Adelphi, show that over 90% of patients who do switch to injectables prefer to stay on it for all of the above reasons: the convenience, the not worrying about taking the daily pill. I actually had one patient who told me he was so anxious every day because he kept thinking he had to take a pill, and that was making him anxious, even though he knew he didn't have to take the pill. It went away finally. Pill fatigue, obviously, everybody's got pill fatigue, and not having to carry the medications. I mean, we all know I'm in Denver, I forgot my pills. All right, not thinking about their HIV status every day. All right, and an exciting point was brought at the core, I believe, ID Week, I believe, and they did a combination therapy with cabotegravir and lenacapavir. So we're crossing companies, and they did a small cohort of 26-week with 34 patients. And I believe the newly rebranded ACTG is actually going to be doing this particular trial, and a combination of subQ lenacapavir every 6 months, and cabotegravir every 2 months, maybe every 4 months. if that moves forward, but I think that's another very good alternative. There will be a long, no pills, combination therapy. All patients but 2 were suppressed and did very well. All right, I will stop there and take any questions.